Happy Friday, everybody. Welcome to the show. We got a great one today. First, we're going to be talking about the big D, and I don't mean Dallas, and I don't mean that either. We're talking about vitamin D and all the things that you need to know about it. Next, we're going to have Wound Care 101, and finally, is my gas stove trying to kill me? We're going to talk about it right now on Nip Talk.
Live from Lincoln Center in the heart of the Dallas Metroplex, this is Nip Talk, an honest and uncensored show about plastic surgery, health, beauty, and lifestyle with your host, plastic surgeon Dr. Bruce Hermann, and your co-host, entrepreneur and social media influencer Sarah Bennett. Now it's time to discuss the good, the bad, and the ugly of the topics everyone is talking about. It's time for Nip Talk.
Welcome to the show, everybody. Thanks so much for joining us. I'm your host, plastic surgeon Dr. Bruce Hermann. With me, as always, co-host Sarah Bennett.
Hey.
In the box is the man and the legend, Trelvis. What's up, man?
What's happening? What's happening?
Not much. How you been?
Good. Happy Friday to y'all.
I know. That's why I love doing the show, because it means it's Friday. it's like the greatest thing. You do the show, and then you got the whole weekend.
Right. We made it.
It's a good thing. We made it through. So, do y'all have good weeks?
Yeah, I did.
Yeah? Anything exciting? Now, I know you got this new gig you're doing. How's that going?
It's good.
Yeah.
Just juggling.
Yeah.
Making things work.
I mean,
that's life.
You and I are kind of the same way. We have like all of these like side hustles we do, so
Yeah.
it's like we're just kind of all getting pulled.
You gotta figure out what is a priority, like every day.
I know.
Like, what's the priority today? It like fluctuates.
I hear you. Yeah, I feel the same way, because like, you know, it's like, of course, the show's on Friday, and then maybe the beginning of the week, I'm more like getting all my, surgery schedules and stuff done, and making sure all the clinics are taken care of. And then as it creeps into the week, it's like, oh, I got to start like planning for the show and, making up segments and getting pictures and videos. And I get it.
We're superheroes.
How's your YouTube thing going? Are you still doing that a lot? Or?
Yeah, I'm trying to figure out if I want to do it anymore. I was like,
you have to keep doing it. You have like so many people that love it.
I think I'm gonna find like an editor,
editor? Oh, okay.
To see some prices on that, because I'm sure like a video for me, like maybe a 10 or 15 minute video is like a max for a video that I make. And so I'm like, I think a seasoned like video editor could probably push a video out probably like in 1 hour.
Yeah,
and
probably
it takes me like
I can actually,
day.
I'll have to introduce you to the people that kind of do some of my editing for me.
Okay.
Yeah, I don't know what they would charge for something like that, but they're really, really good. It's that Paired Up. I think you've met Kaylee before.
Yeah.
Yeah, she's great. But well, I'd hate to see you not do it anymore. I actually watch I get on and I watch your episodes when I see
My daughter watches them a lot.
Your daughter?
She loves them. She loves, because she's,
because she's in it, right?
Yeah. And she's like, we're not making them anymore. And I'm like, I don't know.
She's gonna be heartbroken.
Yeah. I think she liked telling people that her mom is a YouTuber.
Yeah. Oh, of course. Yeah.
Yeah.
I bet that's really exciting for her. Now, Trelvis, your voice is kind of hoarse. I heard you were like yelling at your show. What were you guys talking about, man?
So there was a parade that happened, what was it, Monday? There was a parade that happened Monday, and now my voice is like really hoarse.
Oh, you were on the float.
Yeah, I was on the float.
I forgot you. Yeah. So how was it?
And like a smart guy, I was yelling to people instead of like using the microphone. It was dope. It was really cool. It was really cool.
That's pretty awesome, man.
I enjoyed it. I feel like a beauty queen, just in my little way.
Hey, everybody. Oh, that's really cool, man.
Absolutely,
right
absolutely. How your week been?
It's been good, just working, and I think I told you guys I'm like considering buying a building.
Oh yeah.
And so we're still going through that process, which I'm really excited about, because right now I rent, and it's kind of just like throwing money away a little bit.
Did you find a spot?
Yeah, we did.
You still with the same dude that you're doing it? Yeah.
Yeah, it's a good friend of mine. He's a surgeon, Dr. Tim Larson. He does orthopedics and hand surgery, and we've known each other for like 10 years. And he's a really good guy, and he's looking to like buy his own building. So we're going to go in together, I think, and get something. Or we're working on it. Like we're working on a deal right now.
Yeah.
Right on.
So, but that's kind of taking up a lot of time, because we're thinking about like how we're going to have to improve the building and who's going into what space. And so, yeah, that has been kind of consuming me a little bit for the past couple of weeks, but
It'll be worth it.
yeah, it definitely will be worth it. So, but it's just like, it's one more plate I'm like trying to spin, but hey, that's what it is. Like, I don't know. I'm one of those people, like, if I don't have stuff to do, like, I don't feel right,
Yeah.
Like, if I just had to, like, go and do, like, my surgery practice, I'd be, like, probably getting in trouble, because idle's hands are the devil's playground.
Yeah.
Thanks.
Yeah.
But anyway, so I got that. And I do want to mention, Sarah, I love your outfit. Like that jumpsuit is like really awesome. Like, you remind me of like Kelly McGillis from like Top Gun, or like you're about to like jump into a fighter plane or something. I mean that in a good way.
It would have looked even better if I was wearing my combat boots. That's usually what I wear.
Right.
With it.
Now, did you sell that at your store?
Yeah, I sold. It was one of my first jumpsuits I sold whenever I first.
Was there like a season that jumpsuits were really like in, or are they just kind of always in?
I think the past couple of years they've dropped off a little bit.
Have they?
I just remember rompers. Rompers, like little shorts.
Yeah, I wasn't as big a fan
really
of that.
In style. Right now it's overalls have been really in right now.
Oh yeah,
because
I have
the
seen the overalls.
Are back.
And you did a segment and we saw a bunch of the overalls. Yeah.
So that's kind of back, but I feel like jumpsuits, they're in still, but they're just not as prevalent. They're kind of like especially this type of jumpsuit, it's like a never goes out of style thing.
Yeah.
Yeah. So it's easy to wear.
Yeah.
I was like, what am I going to wear today?
It looks good though. Like I like what's different.
Today.
Like it's different from your normal style. And
yeah.
I was like, oh wow, look at Sarah. Yeah.
Yeah.
I kind of felt the same way. I had a little bit of time after I got done doing surgery.
You're dressed different.
Yeah, I dressed up a little bit today. This is kind of like what I dress up like normally. It's like vintage tee and like a jacket,
That's
jeans.
your going out attire.
Yeah, kind of going out. Yeah, not like super fancy going out, but maybe like, you know.
That's what you wore. That's what you usually wear, like.
Going out on the square.
Or something.
Yeah, this is a good like going out to the square.
I do like the Run DMC shirt.
Oh, thanks.
Too.
Yeah, so this is a 1988 Run DMC tour shirt, like original shirt.
Than leather.
Nice.
Yeah, I love Run DMC. I was a huge fan because like I was like, let's see, in '88 I was like 13 or 14 years old.
I used to watch his reality show.
Oh, really?
Mm-hmm. Rev Run.
Yeah, I didn't ever see it, but but I love Run DMC.
And he would always, at the end of the episodes, he'd sit in his bathtub.
Take a bubble bath.
I was just like, oh.
I may have picked this shirt up at.
Go ahead and wrap this episode.
I may have got this at the Vagabond Vintage there.
Oh, at Vagabond.
You know Vagabond?
Yeah.
Do you?
I recently heard of them.
Yeah, so there's one in Denton, like right where Sarah and I live, and there's one in Dallas and one in Fort Worth. I go there like literally.
We're trying to get them to do the wine tour.
Oh, they should. You know, I know those guys really well. In fact, when they get shirts, they just text me and they're like, hey, we got some shirts that we know that you're going to.
Well, next time you go, tell me you're Cassie.
Yeah, who do you talk to over there?
Oh, we haven't.
Oh, you don't know the names?
Yeah,
So Tony is like the manager of that store. I can text him for you, but I love Vagabond. Yeah, if you live in Dallas and like vintage clothing, there's.
Because it's right next to Steve's Wine Bar, right?
It's right next to the axe throwing and the vinyl lounge. Yeah.
Okay.
Yeah.
Where's Steve's? Isn't that across the street?
Yes, it's across the street.
Yeah. Because we need more people over there.
Yeah. Well, there's Vagabond too in Dallas and Fort Worth. Travis, if you ever want to hit.
I got you. Yeah. I know the one in Dallas. I didn't know it was in Fort Worth. We got a good location like topic, I guess, for the show just now.
Yeah, right.
People
can
kind of like
Dallas, check out these places.
Yeah, exactly.
All right. So I'm gonna move on to the first segment.
Yeah.
And of course, I'm always like looking at like what's in the news. And so actually, my wife suggested this. Thanks, Cindy, if you're watching. She suggested we do a topic about vitamin D. Because like it is in the news like so much, and I didn't really realize that, but when I did a search for like vitamin D like news articles, like it was just like pages and pages like just from this week. And so I remember a little bit about vitamin D from med school, but I'm not sure everybody knows all the basics about vitamin D, so I wanted to kind of just talk about it. So what is vitamin D? So it's a fat-soluble vitamin that helps the body absorb both calcium and phosphorus. And you may or may not know that calcium and phosphorus are really important for bone formation. Also, vitamin D helps with reducing cancer cell growth. If people have cancer, it helps fight infection. It also reduces inflammation. So it's a pretty important vitamin. So the big question is, how do we get vitamin D? Well, there's 3 ways you can get vitamin D. One is the sun, one is foods, and the third way is supplements. And so I brought some questions for you guys. I know you love questions.
Yes.
All right, Travis, throw up the first question. All right, so, and I did not know the answer to this question myself, so I'm not sure I would have gotten this right. But how much sun exposure in a day do you need to get your total allotment of vitamin D? So you think it's 15 minutes, 30 minutes, an hour, or 2 hours? Who wants to go first?
I'll go first.
All right, Travis, lay it on us.
I'll say A.
15 minutes. Sarah?
B.
30 minutes. Okay, Travis, you're right.
Oh, wow, really?
Yeah, so it's about 10 to 15 minutes. Now, that does vary by like how intense the sun is. That 15 minutes is just kind of like an average amount. but it needs to be like 10 to 15 minutes of like pretty like direct like midday sunlight. And so I thought it was going to be more. I didn't realize it was that small of amount. So, but the thing is nowadays, people say stay out of the sun and cover up. And so, it's potential that people could not be getting enough vitamin D from the sun. Also, if it's winter or if you like live in a place that's really cloudy, like, Seattle or Portland or whatever, or if you just avoid the sun. So also there's a follow-up question in that. Travis, throw up the next one, will you? So if all things being equal, what group out of these 4 is more at risk for vitamin D deficiency? Is it Caucasians, Asian, Hispanic, or African American?
I'll say D, African American.
That's what I was going to say.
Yeah. You'd be absolutely right. And the reason for that is the darker your skin tone is, it acts like shade to those molecules that create the vitamin D. And so if you're very fair, then your body makes vitamin D easier than if you have a darker skin tone. So in general, African Americans have to be a little bit more aware of if their vitamin D levels are good enough. So,
I've heard that too.
Yeah, did you know that? Oh, wow,
I've heard
very good.
that.
I actually didn't know that either. Like I learned a lot, like just going over it. I probably knew this stuff when I was like in med school, but
just a little rusty.
Well, it's like, I'm a plastic surgeon, so I'm not like talking to you about, is your vitamin D levels okay before you come get this liposuction or whatever. But I remember, bits and pieces from med school, but refreshing my memory was good. Okay. So we said you can get it from the sun and food sources. So I listed out the food sources that have good vitamin D, and a lot of these I remembered. Fish is really high in vitamin D, and so like where it says salmon, like that's 66% of your daily value of vitamin D can come from salmon. Can of tuna, 35%. I don't know who eats sardines and herrings. I guess maybe in England or something. But you can get 25 to 27.
My dad loved sardines.
I remember eating them when I was a kid, but I don't even know if you can buy them around here anymore.
Yeah, you can.
I don't know.
Cans.
Can you? Okay. Cod liver oil, a teaspoon will give you 50% of your vitamin D. So like an egg or egg yolk, 5%. Mushrooms is the only non-animal product food that I could find that actually provides vitamin D, and it's a fair amount. A serving of mushrooms can give you 17% of your daily vitamin D. Cow or soy milk, 15%. Fortified cereal or oatmeal can have up to 15%. Fortified OJ, 12%. And fortified cheeses up to 10%. So, well, actually, the cheeses don't have to be fortified. Well, I think they are fortified. Some of them are, because I've seen cheese packets that say with extra calcium, or with extra vitamin D, sorry.
Yeah.
So anyway, those food sources can help supplement you if you're not out in the sun a whole lot. So what is vitamin D deficiency? I think I got one more question up here. All right. So there is a disease that comes about from vitamin...
Herpes.
Herpes? Is that your answer, Sarah? No, I'm just kidding.
No.
So is it scurvy, rickets, impotence, or herpes? I think, Travis, you're up. Or I can't remember who's up.
I think scurvy is like a pirate's disease or something
It
like
is.
that.
Yeah.
I'm going to say B.
Rickets?
Oh, man.
Besides, that's the only one I don't know what it means, I guess.
I'm just going to say A.
Scurvy. Okay, so I will tell you, the answer is B, rickets. Scurvy is a deficiency of vitamin C. You're right about it being a pirate's disease. Scurvy was something that sailors and pirates got because they couldn't get vitamin C. And so, have you ever heard the term limey, like a British person?
Like limey?
A limey, L-I-M-E-Y, limey. You guys haven't heard that? Okay.
I have not.
So it's like a slang term for a British person, a limey. The reason they were called limeys is the British Navy would supply limes to their sailors so that they wouldn't get scurvy. And so they were called limeys. Yeah. But the answer is rickets for vitamin D. That's the deficiency disease for vitamin D.
So what exactly, I guess, is rickets?
Yeah, so rickets is a disease that comes about when your vitamin D deficiency is low as a kid and your bone formation can't happen correctly. So you can get malformations of your bones, you get muscle weakness, joint pain, and like these weird growth patterns where, the limbs don't necessarily look like they should. So rickets is very rare because, most kids are out in the sun. Like, kids are generally outside more than adults. So it's unusual that you would find a kid to have rickets these days. Plus, parents are all giving their kids vitamins and they drink milk and all that. But if there was a vitamin D deficiency, that disease is called rickets. So in adults...
Can you have like be like predisposed to have rickets more so than other people? Like if your body doesn't like metabolize vitamin D?
I don't.
Like other people?
There are some diseases that we're going to talk about that yes, you can. Now, as a child, I don't remember seeing any children's diseases specifically that run a high risk of vitamin D deficiency. I'm sure they exist because some adult diseases do and probably would translate, but it's just more rare that a kid would have these diseases.
Yeah.
You know, because generally kids are a little bit healthier. That's a great question. For adults, if you have vitamin D deficiency, you can get fatigue, bone pain, muscle weakness, and also depression. I love when segments come full circle because remember when we did seasonal affective disorder? We
touched base with.
We did, yeah, exactly right. We talked about how if you in the winter there's not as much sun, your vitamin D levels can drop, and then you can get depression, and that's actually.
I have one of my friends bought me for Christmas this little light.
Oh, right.
And it's supposed to feel like sunlight.
Yes.
Yeah.
Yeah, we talked about that. That was a treatment for seasonal affective disorder.
Yeah.
Do you use it?
Yeah, I put it like in my office at my store.
Nice.
I don't have a window. So like if I'm in there all day, like I don't see the windows or anything.
I wonder if that light, do you know if that light will cause vitamin D formation? Is it UVB? Probably not because UV.
I don't know. It's from Amazon. I don't think it was that like super expensive.
Yeah, that's interesting. If it has UVB light, then that does stimulate vitamin D.
Oh, okay.
It might. We'll have to look it up.
Yeah. Anyway,
I'm always by your store. I'll drop in and we'll take a look at it. All right. So how many Americans potentially suffer from vitamin D deficiency? Well, it's actually higher than I thought. You know, because I know I've been on here saying, oh, if you live in America, you know, you don't have to worry too much about vitamin deficiency. Well, I read some studies that said up to 1/3 of Americans have vitamin D deficiency. Now, I think it's a lot of at-risk patients because we're going to talk about people that, you know, are more at risk. But I was kind of surprised. So, and if you think your vitamin D levels might be low, like if you're in one of these groups or maybe you just, you know, hate the sun or whatever, your doctor can check your levels. That's an easy lab to draw. It's not something that's common, so you'd have to mention to them, you know, or maybe hopefully they would mention to you, like, do you get out in the sun or, you know, do you think you get enough vitamins? I don't know. But doctors can check that level. And as far as how much vitamin D you need, so like if you're thinking about it like in a dosage, it's either international units or micrograms. So for most adults, 600 international units, which is 15 micrograms. If you're older, where you need that increase for your bone mass, it's 800 international units or 20 micrograms. So I do want to talk about the people who are most at risk for vitamin D deficiency, because if you know somebody that's in this group, if you want to be like a good friend or family member, you might just mention to them that these are the people that are more at risk for vitamin D deficiency. So postmenopausal women is one. They're always, because you've heard of osteoporosis, right, as women get older. So vitamin D deficiency is very prevalent in that group. Anybody who takes long-term steroids, which is a lot of people, there's a lot of different diseases that require you to take steroids, which affects your vitamin D levels. Elderly people, once again, the older we get, you know, you need that vitamin D for bone mass.
You don't go outside.
Or you don't go outside. Yeah, there's a lot of reasons. People that are pregnant or breastfeeding, like they're more prone to be vitamin D deficiency. The next one are diseases. People who have chronic kidney disease or parathyroid disease. Parathyroid helps regulate calcium and phosphorus. So people with those diseases tend to have a little bit higher risk of vitamin D deficiency. People who are obese don't have as high level of vitamin D, so they're at risk. And we said it early, right at the beginning, African Americans, because they have the darker skin tone. Or, you know, very dark Hispanic, you know, could be in that group as well. So lastly, I want to talk about supplements. There's a huge market for vitamin D supplements. I think most people probably don't need them. Like, I'm not saying you have to run out and start taking vitamin D supplements. It's just, you know, this is the information. Be aware. You know, think about, you know, are you getting out in the sun enough? Are you in one of those high-risk groups? If you are going to do supplements, there are generally two kinds. There's vitamin D2, which is called ergocalciferol. And that comes from plants. And there's vitamin D3, which is cholecalciferol. That's the animal product one. The vitamin D3, the second one, is better. There's been a lot of studies that show that that one is more absorbed and helps increase your vitamin D.
I think I have a vitamin D3 gummy at my house.
Oh, do you? Do you take a lot of supplements or some?
Sometimes.
Yeah.
It depends on like if I'm on a kick or something. Yeah. I mean, I'm always taking protein. That's the only supplement I really take is protein powder a lot. But
because you're working out.
The other stuff, it's like when I think about it, I'm like, oh, that's a gummy.
Yeah, it's like, maybe just make sure my vitamin D levels are good today. Yeah, I'm bad about that. Like, I don't take any supplements really. In fact, one thing I did do this past week. I went to the doctor for the first time in like forever, and so like actually he says in pretty good health. My blood pressure was really good. I don't normally check my blood pressure. I was like 110/70. It's like it's pretty good because I mean certainly someone in my age could have high blood pressure.
Yeah, I've gotten prescribed blood pressure medication.
Oh, you
before.
did?
Yeah.
Oh, was it like around pregnancy or?
Well, I had preeclampsia towards the end of my pregnancy, but I have a tendency to get really, really, really stressed out.
And that affects
my
your
blood pressure goes up really.
I'm like a
high.
pretty chill guy, so like I think the stress thing.
Yeah.
I don't think
I pretend to be chill.
You pretend to be. You seem very chill. Like on the show, it's like I feel like I'm the kind of the.
Yeah, inside I'm like a raging maniac, and you just don't see it.
I guess I could see that.
Yeah, I'm just a good cover up.
Yeah, but no, I probably should get my vitamin D check. Although I'm out a lot, I like to be outside. I like to run, and like I'm that guy that like runs like with no shirt on, just to like scare, but not to scare, but I just like to get sun. Like I do it because I like to. I don't know. I feel better if I have like not trying to like sun tan, but just. I mean, maybe subconsciously I think about my vitamin D, but like I like to get out in the yard and like get sun and stuff. So
well, it's natural.
I'm probably okay
to want to be outside.
Yeah. All right. So vitamin D, I think it's a great topic. I guess the big take home from this segment is, are you in those groups who are high risk? And if you are, it might be something you just check out. Talk to your doctor. So
yeah, I feel it's again one of those things. At the end of the day, if you're eating correctly and being healthy in general, you're not going to have it.
Yeah, probably not. Yeah, I mean, most people in the United States are. I think in that group of 1/3 who are deficient, it probably is a lot of these high-risk patients, like elderly people. They're not getting outside. They're not eating well. That kind of stuff.
Yeah, the only thing I wonder about is I wonder if like the increase of like social media, electronics, all of that stuff has had an effect on the increase of vitamin D deficiency.
It probably like is kids as well.
Yeah,
I mean, when I was a kid, I was outside like all day.
Yeah, I think about my daughter. My daughter, like her idea of fun is playing on her tablet with her cousin that's like in Houston. But I'm like, why don't you go outside? Because like I was outside running barefoot, getting into all kinds of messes.
Times are different, man. Like, I mean, I don't know what to say. Like, my kids are the same way. Like, I mean, they're good kids, but they love to be, they're indoor kids. I mean, we do go out. Like, in the summer, we do out a lot.
Yeah, I make her go camping.
Yeah.
So.
But, all right, very good. Okay, so I know a lot of times that I've just kind of mentioned about the fact that I do wound care.
Yes.
And then I was just thinking, I'm not sure we've ever done like a wound care segment. I mean, it's not something that's glamorous, but it's kind of interesting. So I wanted to do Wound Care 101 today. And so that's a picture of the facility I work at, which I'll talk about in a minute. So for doctors, plastic surgeons generally are considered the highest level for wound care. And a lot of that becomes of our surgical background. Most of us are trained in general surgery, which deals with wounds. And then plastic surgery is trained to either heal or close the hardest wounds. Like if somebody's in an accident and like the ER doctor and the general surgeon are like, I have no idea how I'm gonna close this wound, like that's when I get called. Like so for bad dog bites or crazy car wrecks, motorcycle stuff. But the thing is like not a lot of plastic surgeons like to do wound care, like in a classic wound care type of setting. They may take call in a hospital, but actual wound care like in a clinic, there's almost no plastic surgeons like to do that. But I mean, I kind of like it. I like the challenge of it. Plus like I do it in my hometown, and it's like, for me, it's like one of the ways that like I feel I'm giving back to my community, because I mean, I love doing cosmetic surgery and it's super fun and it's artistic, but is it like helping people medically fix a ton of problems? I mean, yes and no. It does help people.
I feel like it would be like something challenging and different.
Yeah, right. It's challenging. It's different. I love the patients. And so I've been actually director of wound clinics now for over 10 years, which that really makes me like one of the most highly skilled wound doctors around, because one, I'm a plastic surgeon, two, I just have a lot of experience doing it. I worked at a really big hospital for a long time doing it, and then I moved over to this place called Horizon Medical Center. And I really like Horizon Medical Center. It offers us both an outpatient wound clinic, and then we have inpatient, because some people have wounds so bad that they need to come into like a facility. So this is like an LTAC, which is a step down from a hospital. And so it gives me the ability to cover all aspects of wound care that a patient might need. So if it's a simple wound, they can come to our clinic. If it's a severe wound, I can take them to surgery, and then I can bring them back to the inpatient there at the horizon and get them on the right track so they can get healed. So I mean, not tooting my own horn, but I really feel like it's probably one of the best wound treatment places in the Metroplex, just for all of the things that we have there. So I was just going to talk about, like, what do we do there, right? Because, like, if I say I run a wound clinic.
I was just about to ask, like, what's like the what are the type of patients that come in there the most?
Bingo, excellent. So I love that question. So it does break down into like a couple categories that will cover most things. A lot of what we see, and these are some of the hardest wounds out there, are what's called decubitus wounds, which the layman term would be a bed sore.
Okay.
You've heard of like bed sore. Yeah. Somebody's like, really sick, and they're like, in bed and they can't get up, and they get these wounds on their backside. A lot of times they're pressure related, because when people are really sick, say like in an intensive care unit for weeks or months, they're not moving. And so that simple act of like laying in one position for long enough can actually kill tissue, and then you get a wound. And the problem is with decubitus wounds or bed sores is they're always in bad places. If you're laying in a bed, it's oftentimes the sacrum, which is in between your butt cheeks, which is kind of a dirty area. There's also the risk of, urine and stool contamination. And if you're like in a sitting position, so say like you were in a wheelchair 24/7, it'd be your ischium, which is kind of like your butt bones, kind of more off to the side, away from the sacrum. So decubitus wounds are probably the biggest thing I see there. It's a lot of elderly patients, people who are chronically ill.
They have a tough time just recovering from wounds in general.
It's just really sad. I mean, and then lots of paraplegics, so people who've been in accidents or had spinal cord strokes. We have a few quadriplegics that we see that are, completely paralyzed. So I should tell it. So paraplegic would be paralyzed from like waist down, where they can't walk, but they can use their upper body. And then quadriplegics would be paralyzed from like the neck down. Okay. And so those patients are very, very high risk for decubitus wounds. The next things we see a lot of, and this is something that, even when I was in general surgery, never saw or thought of, is what's called venous stasis ulcers.
Okay.
So as we age, the veins in our legs start to, for lack of a better word, wear out.
Okay.
And they don't pull the blood out of our legs. Like the arteries push blood into our legs very strongly, and then if the veins can't bring it back out, what happens is the legs start to swell. And when the legs start to swell enough, the skin will start to break down, and you get these really superficial wounds on the legs, basically from your knee down to your feet. And they can be really, really severe, and a lot of times what will happen is if they're not treated properly, they'll get an infection, and then the infection makes it worse. And you can literally like end up having to have an amputation if they're...
Yeah, I've heard of that. I've seen some of older relatives in my family. They'll wear like those compression socks to make sure that
that's exactly right.
Their legs are still circulating correctly.
That's exactly right. And some people just don't think to do that, or they don't have the resources, or maybe they can't put their stockings on, or they don't know where to buy them. And so we get a lot of patients that these will start to develop, and then we will treat those for them. The other thing I see a lot of is complex surgical wounds. So this isn't a case of like, say someone has like a C-section and there's like a little breakdown and then they send them to me. I mean, I would see that. That'd be totally fine. But the wounds that I'm talking about are the more severe wounds. So a wound that potentially is complicated with something like hardware on a bone, or one thing I see a fair amount over there is necrotizing fasciitis. I know we've talked about that before just briefly, and we should do a segment on that because it's really interesting. So that's the flesh-eating bacteria.
Yeah.
It's not common, but when patients get that flesh-eating bacteria, they will end up with the most massive wounds that you can imagine if they don't die, because it's a very lethal disease.
This is a weird story. My dog got a wound on his paw, and it would not heal.
Really?
And he was at the vet for forever. I don't know if they ever found out if it was that bacteria, but it would not heal.
Really?
At all. And
did he
had to
survive?
he had to take water like baths.
Yeah.
Like
we'll talk about treatment.
All this stuff,
sounds
and
good.
he was in there for a month. And to this day, it was expensive. To this day, his hand or his paw is like still not exposed, but like sometimes it'll get like
opens
raw.
up.
And it'll open up.
That's crazy. And you don't know what caused that wound to develop?
No, I mean, I do. It was from putting his hand underneath a fence and like pulling it out really
so
fast.
he kind of shaved some of the skin off?
Yeah, he was trying to get another animal.
Or fur, I guess.
Yeah, it was bad.
Interesting. Yeah. I would say it probably wasn't a necrotizing infection, only because the fatality rate of something like that is sky high. And no offense to my veterinary colleagues, if the animal got necrotizing fasciitis, they're gonna die.
Yeah.
Like, I mean, it's a all.
Yeah, I don't think it was that either, but they were like, we might have to amputate his leg.
Yeah.
And I was like, no, you're not. Do everything you can. You put him in those water baths, and
I bet that was expensive.
It was.
We had a dog that our old Doberman that passed away. God bless him, because he was a great dog. Yeah, he was in the vet just for 3 days when he was kind of going downhill, and it was like a couple $1,000. Like, it was expensive. Yeah.
It was bad.
It's amazing what we do for our pets. So the other thing I see, or that we see now, I don't see these specifically, but diabetic foot wounds. So diabetics are very prone to get wounds on their feet.
Yes.
Now we have podiatrists, which are special doctors that just deal with feet issues, and so Dr. Richie Smith works with me. She's a great podiatrist, and so she sees all the diabetic foot ulcers at our facility. So, so that's the kind of things we see. A lot of bed sores, venous stasis ulcers, very common, traumatic wounds, surgery wounds, you see lots of those. And some of those are super interesting. I'll have to get like a collection of some photos that people would let me show. I told you about the guy. There was a guy who got necrotizing fasciitis of his penis and his scrotum. Yeah, I ended up fixing it. Well, I didn't like recreate his penis or anything, but I got that wound healed. I treated it and then got that all closed. And I'll have to talk about him today because he was super, super nice. I was like, can I talk about your story sometime? He's like, yeah, sure. So I'll have to bring that up. It's pretty crazy pictures though.
How do you get that bacteria?
Well, it's actually bacteria that are normal bacteria, but the difference in the necrotizing infections, they get into the tissue planes that are avascular where your body cannot fight the infection. And they start replicating in those fascial planes. That's why they call it fasciitis, because the bacteria is spreading on the fascia, the muscle.
Yeah, because I mean, it's just like when you get a staph infection or MRSA.
Yeah.
It's like that stuff's already on your skin.
Right. Yeah, there's a couple bacteria that are known for causing necrotizing fasciitis, but a lot of times it's multibacterial. Unfortunately, it's kind of just one of those things that can happen to anyone.
Storm.
It's a perfect storm, but it's just thankfully very, very rare.
Yikes.
The one thing to know about necrotizing fasciitis, not to spoil the segment we're going to do someday, is the hallmark of necrotizing fasciitis on physical exam is pain way out of proportion, which means someone might have like a little spot that just does not really look like it's anything, but when you touch it, they just scream.
Right.
It's pain out of proportion is one of the hallmarks of necrotizing, and that's early, because if it goes more than like a day or two without somebody doing something, they're dead. Like the mortality rate is 50% of patients that get treated. Patients who don't get treated, it's 100% mortality. It's crazy.
Scary.
We'll talk about it.
Oh.
All right, so back to the wound clinic. We do see a lot of the necrotizing fasciitis there. So I want to talk about steps to get a wound healed. And I think there's a little bit to be learned about this because some of these things can be used on maybe a wound that you might get at home. And I always tell people if you get a wound, it's always best to go talk to your doctor, obviously. But not everyone does that. And for minor stuff, kind of like when you burned yourself that one time when we were talking about it, it's like yeah, you're not going to
another burn.
Yeah, it's like you're not going to go to the doctor for that. So some of these like principles of wound care are actually very helpful for people who, aren't going to go, or like say you're stranded out in the wilderness and something happens. So the first thing I do if I get a wound in the wound clinic or I get a consult in the hospital is I want to clean that wound of any dead tissue, any infection, and any areas that are hidden. So what hidden means is like if there was a small hole in a big tunnel, because those are very difficult to heal, and that happens quite a bit. So one of the first things that I do for a wound is I'm going to, if it's not in good shape, is I'm going to debride it. And that could be something I do in the clinic or oftentimes I do in surgery. That's what I was doing this morning actually, was a wound patient in the hospital. The next thing I want to do to get wounds healed is I want to fix any external factors that could be inhibiting it. So there's a couple things that really stand out. One is diabetes.
Okay.
So obviously I can't cure you of diabetes, but I can control your blood sugars. So if you're diabetic and you have a wound and your blood sugars are 400, your wound is not going to heal.
Yeah.
But if you're diabetic and it's under control with either medicines or insulin, then your wounds can actually heal. So diabetes, smoking is a big one. Smoking constricts your small blood vessels, and it really, really inhibits wound healing. So if you have a wound or a family member has a wound and they're a smoker, they really are kind of putting up a roadblock on themselves to heal. The last thing would be if there's any arterial issues. And so this is more for like wounds on the lower extremities or the feet. A lot of times as we age, just like our heart can get blockages, our arteries in our legs can get blockages. And so the blood flow is diminished to where the nutrients can't be sent down to the wound to heal it. So when we see patients with extremity wounds, mostly lower extremities, so like feet or lower legs, we'll run studies to see if their blood flow is okay. And I've had plenty of people come in with a wound that they say, oh, I've had this wound for a year and it won't heal, and then come to find out they have arterial blockage. We send them over to get that fixed, and then suddenly their wound heals. I mean,
cool.
that happens all the time. The next thing you want to do is stop any contamination. So this is mostly when talking about more like pressure wounds, like bed sores. A lot of these patients that are older have issues with continence, like urinary continence and stool. So if you get a wound that's getting urine and stool contamination frequently, I don't want to say you can't heal a wound like that, but it really, really makes it more difficult.
Yeah.
So there are things that you can do to control that. I mean, sometimes we have patients that are so infirm that we have to do things like get them a colostomy so that their stool is not, coming out where it normally does.
Yeah.
And sometimes it just has to be done, or you can't get them to heal. Next is you want to eliminate any swelling. So this is more for extremity stuff. Like if you have like a wound on your arm and you have swelling for whatever reason, more commonly the venous stasis where the legs get swollen, like you were talking about your family members, you said the right thing, compression. And compression can be applied many ways. It could be like a stocking or an actual dressing, but that's one of the first things that you got to do if you have extremity wounds is you want to get that swelling out. Next would be avoiding pressure. So this once again goes back to like decubitus or bed sores. A lot of those are pressure wounds. You sit in one location, you don't move, that pressure kills the tissue, and that causes the wound. That same effect will also inhibit wounds from healing. And so you want to make sure that if it's somebody who has a pressure wound that they're offloading, making sure that they're like shifting from side to side, either in a wheelchair or bed. This is something we have to teach patients that are paraplegic or quadriplegic, especially if they're, more recently like that, to take pressure off. Once you get all those things set up, then you can actually start the wound care. Now, I could talk for a full day about the different methods of wound care. There's a ton of products out there, but I will say that there are two things that we use most frequently. One would just be a standard saline or salt water wet to dry dressing. So you have a wound, you get some gauze, you soak it in saline, you put that wet gauze in there, you put a dry one over it, and you change that once a day. And that's a very, very effective way to treat wounds. And so like if I was on a deserted island and, in the plane crash, I got a wound on my arm, I would take strips of cloth, I'd boil water, I would get that water, put it on the cloth, put it in the wound, and then change that daily. And you could actually get a wound to heal out in the wilderness by just following that very simple method. It's very effective. Another thing that we use a lot is a vacuum dressing. Have you guys ever heard of that?
Yes.
Yeah, oh cool. So vacuum dressings are newer technology, came out probably about 20 years ago or maybe a little bit before that. Actually, it's a little bit before that, 25 years or so. So it uses a sponge in the wound to which you apply suction, and then that sponge tricks the tissues into replicating. It has to do with the actual sponge pores, and when it's applied to suction, it causes those cells that it's in contact with to deform, and when those cells get deformed, it makes them replicate. So it tricks the wound into like filling itself. It's really cool. It's great technology. We use it all the time. The other thing with wound care is whenever you're changing that dressing, you do want to clean your wound with soap and water. I swear, there are so many even doctors out there that will tell people not to get a wound wet, and that is total nonsense. It is absolute nonsense. If you have a wound and you're treating it, cleaning it with soap and water is literally one of the best things that you can do because it'll get the bacterial count down. It'll get any cellular debris out that's inhibiting the wound. So cleaning with soap and water is very important. And then lastly, for our wounds, we consider is surgery something that they need. So can I just close this wound with some stitches? Do I need to put a skin graft on this? Do I need to do a flap? And that's once again why I think that the wound program we have is so good, because a lot of wound care facilities don't have a surgeon running it. So if they find a patient that needs those things, like, oh, now I gotta find a surgeon to send this patient to. And I can just do it myself. I just admit the patient to the hospital and take care of them. So, wound care 101. What do you think, Travis?
I've never heard of the other wound that you mentioned. I think Sarah said she had heard of it.
Which one?
What was that one that you had heard of just now, Sarah?
Oh, the venous stasis ulcer?
No, the suction.
Oh, the wound vac.
Yeah, the wound vac.
Oh, yeah.
I've never heard of that one.
Yeah, that's pretty new. I think most people that are not
I didn't really know what it was. I just knew.
You've heard of it, yeah. Most people that are not in medicine, unless they had a family member that had one, would probably not know about it. It's just a more new, advanced type of wound care that's actually very, very effective. We use wound vacs all the time at the wound clinic.
Yeah. So like I have another wound story.
Bring it. I love wound stories.
So my ex,
who says that?
My ex got MRSA when he was in basic training, and he came.
Where did he get MRSA?
In Georgia.
No, I meant like where on his body?
Oh, right here.
On the leg. Okay, so he had a MRSA infection on his leg. Okay.
Yeah. So and it was an infection. So like there was just it looked like something had bit him, and it hurt really bad.
Oh, yeah.
If he touched it or if I touched it, it hurt really, really bad. So I took him to the doctor, and they're like, "Yeah, that's a MRSA infection," and they just like literally dug it out, and I had to clean that thing.
So you did some wound care?
Yeah, I cleaned it every day.
Nice. Soap and water?
I had to, and
nice. You did the right thing.
What's that stuff that's in the blue? Hibiclins?
Hibiclins, yeah. So that's like an antibiotic.
He had to hibiclins his whole body every day so that it wouldn't spread.
So I'll tell you
They were like a very, like, he needs to
yeah.
make sure it doesn't spread anywhere.
I mean, you guys have heard of MRSA, right?
Yeah.
Travis, MRSA?
I've not.
Okay, all right. So MRSA stands for methicillin-resistant Staph aureus.
Yes.
So Staph aureus is a bacteria that we have on our body. We all have it, okay? So in the old days, all Staph aureus was sensitive to penicillin or methicillin. And in the 90s, a new variant of staph came out that was resistant to penicillin. And at the time, it was a big deal because there were not all of the antibiotics that we had today. And if you got a MRSA infection and it was bad, they couldn't treat it because there wasn't an antibiotic out to treat it. So MRSA was like a huge deal. Now, here's what happened. Over the next years and decades, MRSA completely replaced the standard Staph aureus to the point now that every single person, I think, in America has MRSA. I know I have MRSA because I work in a hospital, but even like babies who are born have MRSA because their parents have it. So when people say that they now have a MRSA infection, it doesn't mean what it meant 20 years ago, because now everyone has MRSA. All infections these days are MRSA. It's weird to find one that's not MRSA, but it's less important now because there's so many different antibiotics that will treat it.
Yeah. Well, that's what they said, and so like I used to have to pack it too. They cut it. It was deep. It was like this deep in his leg.
So you packed it with gauze. Yeah, so that's like a wet to dry dressing. You may not have had to put saline on it. Some of those packings have medications on them, like iodoform gauze is one. Was it strip gauze they use?
Yeah.
Okay, it's probably iodoform.
Yeah, and then I had to wrap it up. Every single day.
Look at you doing wound care. I'm gonna hire you at the wound clinic.
Yeah, it was good times.
Good times. All right, moving on. So, you know I love to do topics that are in the news. And did you guys hear about this gas stove debate?
No.
I lightly heard of it.
Lightly heard of it?
Yeah, I lightly heard of it.
Okay. So you know me, I'm always on social media just because I do a lot of social media and I just want to keep up with the news. So this past week, there has been this raging debate about, of all things, gas stoves, which I find just comical.
Yeah.
And it's become political now. There's sides are being chosen in political parties of who's for or against gas stoves.
Okay.
Like, it's just kind of craziness. And so I was like, I wonder if there's anything to this, because I myself had never heard that gas stoves are potentially harmful, and I found that odd being a doctor and being someone who tries to keep up with things like this. This was kind of a new one to me. So obviously got to do a segment about it. So it all came about because Richard Trumpka, who is one of the commissioners of the U.S. Consumer Product Safety Commission, said that the federal government may, moving forward, ban gas stoves. Now, this would not be that they come into your house if you have a gas stove and rip it out. This would be for like new construction. Okay. So like new houses. So I was gonna ask you guys, do you have a gas stove? Travis, do you have a gas stove?
No, I do not. My grandma does have a gas stove.
Your grandma has one?
Yeah, my grandma has one.
So we have gas stove in our house. And
yeah, most like professional chefs.
Yeah. Oh, yeah.
I've always heard gas like cooks better.
Without question. You guys know I love cooking. I think I said that. I love to cook.
I like to cook too sometimes. Oh.
I love to cook. And so I would be lost if I didn't have a gas stove.
Yeah.
Like, I hate cooking on electric stoves. So in the United States, about 38% of homes have gas stoves. In some states, it's as high as 70%. So they're saying that gas stoves pose a risk because of the indoor air pollution, okay? And that there may be a link from the indoor pollution of a gas stove to childhood asthma. And so Trumka actually posted a study. I think I took a picture of it. It was a brand new study in the International Journal of Environmental Research and Public Health. And the basis of this study said that gas stoves account for around 12% of all cases of childhood asthma. Now, you know how I am. If I see a study, I'm going to read it because a lot of these studies are not necessarily what I would consider quality or good studies. Mm-hmm. And I do have some serious concerns with the studies. I mean, the way the study worked is it looked at old papers first, and then it looked at states that had high levels of gas stoves and compared how high the childhood asthma was, and then tried to make the association that in states that had a lot of gas stoves, the children were more likely to have childhood asthma. And so there's a saying that we have in medicine or statistics or whatever that correlation does not equal causation, which means just because two things might happen together does not mean that A causes B. And so I feel like that's the case with this. You know, this is not a good study. A good study would be, I have 1,000 homes that have a gas stove that have a new baby, and I have 1,000 homes that don't have a gas home that has a new baby, and then you calculated what percentage of those babies in each group got childhood asthma. Then you could say, okay, that's a good study. It's looking specifically at the two factors that we want to look at and what's the outcome. So this study was not like that at all. And so the study is kind of weak in that. But also there's a lot of studies that came out before it that say that gas stoves either don't cause problems or they're inconclusive. So I have a little bit of question about this study. Because I guess the thing is, it's like, should you be concerned about this? Well, I'm not going to tell you to be concerned or not be concerned. I'm not concerned. Like, I don't have like this big worry that my gas stove is causing my, kids to get sick.
Sounds made up.
Or me to get sick. And so, yeah, I don't know. I mean, anytime there's combustion, there are products. So the things that they're worried about are carbon monoxide and nitrogen dioxide, that those things can cause, asthma. And carbon monoxide can kill you. Like, it's a deadly gas. And so, I personally don't see the worry. I think that if you were concerned about it, like the ways that you could alleviate your concerns are, one, turn on your overhead vent, because almost everybody that has a gas stove has got a vent. I mean, I don't always use mine. I just use it like if I'm really kind of...
It's getting a little heated.
It's getting a little heated and like there's smoke coming up, because mostly I just don't want to set off my smoke alarms. But use your vent, and then don't have kids. But so I wanted to like take a step further, or no, don't have kids in the kitchen. Like, I don't mean don't have kids. Don't have kids if you want a gas stove.
Warning.
But I wanted to actually do like a little in-home study. So I was going to buy a spectrometer. They're really expensive. So I was like, well, I'll just buy a specific one. So I was like, I can buy a carbon monoxide detector. I was going to buy a nitrogen dioxide detector, but they're in the multiple hundreds of dollars.
Ew.
But I bought a carbon monoxide detector, and I wanted to see, because I wasn't sure what the answer to this was going to be, is my gas stove putting out enough carbon monoxide that I need to be worried? Now, Travis, can we run that video but keep my mic on?
Yeah, we can.
Okay, let's run this video. All right, so this is my carbon monoxide detector. I'm in my Blazer right now. It started. I don't know if there's a little bit of volume. So the 0 is carbon monoxide, 63 is the temperature. So as I get close to the tailpipe, you can see that number starting to rise pretty quickly. So I get down close to it. It's 50. It's going to go hundreds, 200s. So the numbers to know is like less than 100 is generally pretty safe. Over 200 is dangerous. Over 800 is lethal. All right, so this is a campfire. This is my backyard. So 0. Now watch this thing as I get close to this campfire. All right, starting to go up, 30, 40, 50, 60, 70. I couldn't get close enough to the fire. I had to move back, so I was starting to get really hot. But like the closest or the highest I could get was about 70. Okay, this is my house. This is one burner of my gas stove. 0, 0. So I was like, well, maybe it takes more than one. I couldn't get it to go off with one burner. I tried multiple angles, different things, no luck. So I was like, well, let me try all 4 burners at once. So here in a second, I'm gonna swap. Oh yeah, I was trying to see, well, maybe the carbon monoxide's up here. I couldn't get it. All right, so now I got all 4 burners running. You can see the temperature, 86 degrees, it's getting really hot. I put that thing everywhere. I could not get it to go off. It just was 0, 0, 0. And then I finally figured out how to make this thing go off. Like, it's gonna show you here in just a second. And I had this thing here for like 5 or 10 minutes. So this is like 10 minutes later. So look at the temperature's going. It's like 92 degrees now of me holding it above these 4 burners, and I had yet to get this carbon monoxide thing to go off. But I figured it out. What I had to do was actually hold the detector literally over the burner. Watch. But as soon as I pulled it away, it went right back down.
Wow.
And so I could get it to go about as high as 20.
Okay.
Which means that if you put your face directly over a burner for like 2 or 3 days, you may or may not get a little carbon monoxide effect. Like,
you
so
know,
basically,
that's like the biggest rage right now, putting your face over the burners for a couple days. Everybody's doing it.
Everybody's doing it.
Some
Well, that's what it
epidemic.
would take for you to get any amount of carbon monoxide to potentially be an issue. So I thought it was kind of a fun little test because I didn't know if potentially there was a lot of carbon monoxide coming off my burners. But I mean, as you could see, you get way more from like a campfire. Like like burning gas is pretty clean burn compared to burning like wood or leaves or whatever. But even like the campfire, you know, as I said, the numbers for carbon monoxide, you know, less than 10, completely safe. If you're like at 50 for more than 8 hours at a time, then you are starting to run a little bit of risk of having some symptoms. It's really over 100. That's kind of the limit for OSHA, like for work exposure. Like, you know, if you're getting exposed to less than 100 at work, like OSHA's not even gonna really get upset about that. So even around a campfire, it's not that big of a deal. I would say though, if that fire was burning in an enclosed space like the studio, that carbon monoxide would build up very, very fast. And that's, you know, potentially deadly. Most people that die in house fires don't die from the flames, they die from carbon monoxide poisoning. But I really wish, I probably should have just bit the bullet. I would love to, if I'd have got a nitrogen dioxide tester and it didn't show anything, then I would say this study's total nonsense. Like, I mean, there's nothing to be concerned about. But I don't know about the nitrogen dioxide, so, you know, maybe that is an issue with these things. I just don't see it. You know, I would think that if this was an issue, you mentioned chefs using gas burners. How many gas burners do you think are in a steakhouse burning? I mean, we don't see like chefs and line cooks going down from, you know, asthma.
That's Gordon Ramsay.
Maybe Gordon Ramsay will come on the show and we can ask him about it. I would love to have some good guests. That'd be awesome. We got to start having guests. Travis, you know any famous people?
I do not.
Oh, man.
I do not.
All right, we're going to have to start making some good calls. But anyway, so I thought that was a really interesting thing. It was something I'd never heard of. When it came out, I was like, I got to look into this. I have to say, and I'm not like a left-right person, so like I'm not saying that I don't think it's a problem because of any political affiliation. I'm really kind of not affiliated with any political party, not to get into politics at all, but I don't think it's a big issue. I just don't, I don't believe it. Like the research doesn't conclusively say that it's a problem. I think if you have a gas stove, you keep using it. I am gonna be pissed though if like the government tries to ban those, because I mean I have one now, but if I wanna like move,
right.
I don't think it's gonna happen.
I don't think it's gonna happen either. I mean, people.
For that to happen, I feel like it would have to be like a way more of a controlled experiment.
Yeah,
for them.
I agree. I think people are just wanting to make waves, and you know, this Trump guy probably just needs some attention. So it's like, oh, we're thinking about banning gas stoves.
Maybe he works for GE Electric.
Probably.
GE Electric is paying him off.
Anyway, I thought it was kind of cool. It's interesting to talk about. I'm not going to be too concerned about it. So.
Yeah.
All right. I think that's about all the time we have for today. Thank you so much for watching the show. If you have any questions about anything we talked about, please leave us a comment, and we'll see you next week on Nip Talk.
Bye.